Hello, my name is Melanie Mora Romero and I'm going to talk about Apixaban for the treatment of venous thromboembolism associated with cancer. Definition: venous thromboembolism is a common cause of death and complications in patients with cancer. The high risk of recurrent thromboembolism and bleeding in patients with cancer makes anticoagulant treatment challenging. So, specific studies involving these patients are necessary. Applications in medicine. Major guidelines recommending the use of low molecular weight heparin for the treatment of cancer-associated venous thromboembolism and have recently added the use of edoxaban or rivaroxaban. However, the clinical benefit of these oral agents is limited by a higher risk of bleeding than with low molecular weight heparin, mainly occurring at gastrointestinal sites. Pros and cons: there was no increase in major bleeding or GI bleeding. Among cancer patients, treatment guidelines recommend low molecular weight heparin, edoxaban or rivaroxaban. However, edoxaban and rivaroxaban have been associated with an increased incidence of GI bleeding. Issue applied in Ecuador. The most recent guidelines recommended the use of edoxaban or rivaroxaban for the treatment of venous thromboembolism associated with cancer. Conclusion: oral apixaban was non-inferior to subcutaneous dalteparin for the treatment of cancer-associated venous thromboembolism without an increased risk of major bleeding.
Patients with cancer have an increased risk of venous thromboembolism, but parenteral thromboprophylaxis is not routinely recommended in practice guidelines because the absolute risk reduction is modest, and parenteral thromboprophylaxis is associated with an increased risk of major bleeding as well as the inconvenience of daily injections. Could a direct oral anticoagulant such as Apixaban, used as a thromboprophylactic agent in patients with cancer, offer advantages over parenteral agents, particularly with regard to convenience? The randomized placebo-controlled double-blind AVERT trial included ambulatory patients with cancer who were at intermediate to high risk for venous thromboembolism with a Khorana score of 2 or more. The Khorana score has been validated to identify patients with cancer who are at elevated risk for thromboembolism. The trial patients were randomized to Apixaban for thromboprophylaxis before chemotherapy or to placebo before chemotherapy. The primary outcome was objectively documented venous thromboembolism over a period of 180 days. In a modified intention-to-treat analysis, venous thromboembolism occurred in 4.2% of the 288 patients in the Apixaban group and 10.2% of the 275 patients in the placebo group. The number needed to treat to prevent venous thromboembolism was 17. The main safety outcome was major bleeding. Major bleeding occurred in 10 patients in the Apixaban group and 5 patients in the placebo group. The authors conclude that Apixaban at the initiation of chemotherapy resulted in significantly lower rates of venous thromboembolism than did placebo among intermediate to high-risk ambulatory patients with cancer. The rate of major bleeding episodes was higher with Apixaban than with placebo. Full trial results are available at nejm.org.
Venous thromboembolism is an issue in cancer, and there are guidelines about how to treat it, but you're looking into perhaps considering whether the guidelines are right or giving people advice. What did you do in this study that you're reporting here?
Yeah, so we looked at practice patterns of what anticoagulants are used by clinicians and by patients in the real-world setting. And this was data from 2013 and 2014, so it's really, really new. And what we found was that even though low molecular weight heparins are the recommended guideline treatment, only about a quarter of patients were getting that, and half of patients were still getting warfarin, which is a much older drug, and about a quarter of patients were getting rivaroxaban, which is one of the newer agents in this setting. What
do you think are the reasons for that, even though low molecular weight heparin is in the guidelines?
Well, one big reason is convenience. The low molecular weight heparins are daily self-injections. Cancer patients are already going through a lot of stuff, and to add a daily self-injection is problematic. A second reason is cost, especially in the United States. The cost of the low molecular weight heparins is substantially greater, and direct-to-patient costs can also be quite high depending on the type of insurance, health insurance that patients have.
So from your investigation in the real-world setting, what guidance can you give us now on this?
Well, it sounds like, and it's not just our abstract, but there are a couple other abstracts presented today, and it appears that using novel oral agents such as rivaroxaban is appropriate in some settings, and in carefully selected patients. The guidelines will need to take this information into hand before making new recommendations. And there are certainly high-risk patients who are at really high risk for getting blood clots come back. And in those patients, it's still appropriate to use low molecular weight heparins.
So really, there's a case to be made for looking into this rather seriously and perhaps revising guidelines, do you think?
Absolutely. I think there needs to be a risk-adapted approach where we make one recommendation for patients who are at high risk and a different recommendation for patients who may not be as at high risk for recurrence of their thrombosis.
So how would you distill what doctors need to remember coming out of your piece of research here?
Yeah, so number one, is that many of these patients were admitted to the hospital for treatment of their thrombosis, and that's not really necessary. Many of these newer agents and even the older agents can be successfully treated in the outpatient setting. So no need to admit the patient to the hospital unless they're really sick. Second, use the appropriate anticoagulant depending on the setting. And third, sort of keep patient-centeredness in mind. Patient preferences are important in this setting, whether related to cost or other preferences, and that should be kept in mind as well.
And many patients could be on an oral NOAC.
It's certainly possible, yep.
Patients with cancer have an increased risk of venous thromboembolism, in part because malignancy is associated with a hypercoagulable state. Approximately 20% of all VTEs occur in patients with cancer, and the risk is greatest in the first year after diagnosis and in patients with metastatic disease. Despite this, thromboprophylaxis is often underused in this patient group. This may be because the impact of VTE in patients with cancer is underestimated, but also because chemotherapy leads to a weakened vasculature, which can increase the risk of anticoagulant-related bleeding. Some patients with cancer were included in the studies of non-vitamin K antagonists or anticoagulants for the treatment of patients with VTE, but in general, there have been a few large phase 3 studies of anticoagulation in these patients. Find out more about thrombosis and cancer in this section of thrombosisadvisor.com, including recommended strategies for prevention and treatment, as well as information to help balance the benefits and risks of treatment.
Some of the things that I think are going to be really exciting about the rollout of these guidelines are that since the last guidelines were published, we now have 4 new drugs that are available on the market for people to prescribe, and we don't have any guideline information about how to use those. And so one of the things that was really exciting for our panel is that we are able to dig in and try to make some recommendations about how to use those drugs in the treatment of people with venous thromboembolic disease. And it was really exciting, but it was also challenging because the drugs are new enough that a lot of the information about questions that people are grappling with, there might not have been as much evidence. But the really great thing was in the room, in the panel discussing this, were the experts and the people that really have their finger on the pulse of what's going on out there clinically. A novel thing about these guidelines is that the plan is to continually update them as much as possible in real time. And so I think our panel will get the opportunity to add additional information, and as new drugs come onto the market, there's many that are in the pipeline right now, we'll be able to add to the recommendations that we've made and continue to inform people about the optimal use of anticoagulant drugs.